The development of the dentition appears like the start in a Formula One car racing. And like in car racing, things can also go wrong during dentition development. Let us have a look at this computer-animated movie we made. When the milk teeth have not even erupted yet, mineralization of the incisors of the permanent dentition already begins. And when the first deciduous incisors have erupted, the incisal edges of the permanent incisors can already be clearly seen. And also the cusps of the first permanent molars are already formed now. And as soon as the primary dentition is completely formed at the age of 3, its roots are already being resorbed again. And you can now also see the space needed for the permanent incisors to erupt as compared to the size of the primary incisors. And that is why they are moving apart. And from the side, we can now see the size discrepancy between the deciduous molars and the erupting bicuspids. That is the space reserve, which we call the leeway space. And at the very back, the crowns of the second permanent molars are just forming. And if there was still a gap between the incisors in front, a medial diastema, when the canines erupt, this gap is usually pushed together. And then the dentition is fully formed. So we have just seen the film on the development of the dentition, and now we can also formulate our learning objectives more precisely. First, we want to define some technical terms. So what is the first dentition? Which are the milk teeth? And what are accessional teeth? And which are the successional teeth or replacement teeth? And then what are the permanent teeth? We go on then in detail about the time sequence in development of the dentition, and on the way to the fully developed occlusion, there are differences in the speed of development of each tooth. The teeth change their positions, and at the same time, they do resorb their deciduous predecessors. As clinical consequence, we have to take care of the eruption processes, of space control for eruption, and we also ask ourselves, how do teeth erupt at all?
You will of course find everything we discuss here in this lecture in text and pictures in my textbook Oral Structure and Biology. That is why I always include the page numbers at the top left of the slides. If you want to know more, I can recommend the works of Frans van der Linden. He has spent his whole life studying orthodontics and the development of the dentition. Here are his textbooks. And on the far right, this volume shows from our videos from the series Dynamics of Orthodontics. We produced these a quarter of a century ago, and everything that moves was visualized in motion using computer animation, including the film about dentition development that you saw at the very beginning of this video.
So, to begin with, some definitions. First, the primary teeth. These are also called the deciduous teeth, which erupt between 6 months and 30 months, and they are replaced completely eventually. And we want to define further, then we can look at this panoramic radiograph, and there are the deciduous canines and the deciduous molars. They are still present as the teeth of the milk dentition. The first, second, and third permanent molars are called accessional teeth, whereas there are some people who do not even possess third molars. Maybe they have some out of 4, or even completely none. They are called accessional teeth because they do not have any precursor tooth. successional teeth are all those permanent teeth which replace their deciduous precursor. So these are the permanent incisors, the cuspids, and the premolars, or also called the bicuspids. And then the permanent teeth are all those teeth which make the dentition after the shedding of the deciduous teeth. And here in this scheme, it may become clearer now. I have distinguished the white milk teeth from the permanent teeth depicted in gray. Well, this is only a scheme, indicating the dental primordia. And now you can see that the incisors, the canines and the premolars, also called bicuspids, they arise from the dental lamina of the preceding milk teeth. The first, second, and third molars, on the other hand, they originate from the distal extension of the general dental lamina, and accordingly they have no predecessor. Now, there is still some controversy in the literature whether the permanent molars belong to the first or to the second dentition. So there are people who ask themselves these kind of questions. So, as these molars do not have any successors, they probably do not belong to the second dentition. Or, because these molars have no predecessors, they must actually belong to a first dentition. I think this question is irrelevant here. This dispute can be understood only against the background of the theory of evolution, and that does not really belong here now. I have decided they belong to the permanent dentition, and therefore I have shown them in gray. And after all, they have the typical enamel color and the size of the permanent teeth, without any doubt. We can again summarize the development of the dentition with these still images and get an orientation for the time sequence. So at the very beginning, the size discrepancy between the milk teeth and the permanent teeth is shown here again. And when the deciduous dentition is completely formed at the age of 3, you can already see some of the permanent teeth. And if we look at it exactly in a dorsal view, we can see how the permanent incisors, which have long since finished developing their crowns, are pushing the primary incisors apart. It is a good sign when the children's primary dentition develops these kind of spaces. Then we know that there is enough space for the permanent teeth, which are bigger. We also see a size discrepancy in the lateral teeth. The deciduous molars, they are significantly larger in their sagittal dimensions than the subsequent premolars. And this is a space reserved in the dentition which is called a leeway space. We will discuss the importance for the development of the dentition in more detail later in this lecture. Okay, and here the dentition is completely formed. As a summary, I will now run the movie again. But without any comment, you have already understood the essentials, don't you? The development of the dentition is actually quite complex and confusing, especially when it comes to the time sequence. But it helps if we use the number 6 as a rule of thumb. At 6 weeks after conception, the formation of the dental lamina of the first dentition begins, and in the 6th month of prenatal development, the deposition of dentina and enamel has just started in the incisors of the first dentition. And everybody knows that in the 6 months after birth, the first milk incisors erupt. This is then usually a little party for the parents when the first little teeth of the baby can be seen. And if we stay with the number 6, then we come to the 6 years of life, which is then the time when the tooth change begins in the anterior region and when the first permanent molars erupt. Here in the chart, it is now saying 7 years, but You can also see that it has plus and minus 9 months as an individual variation. And these values are constantly updated worldwide. So it's not really wrong to remember the number 6 for this. And after all, the first molars are also called 6 years molars. Well, and with the double 6, then at the age of 12, the teeth have also changed in the posterior region and the second molars emerge, the 12 years molars. But this is only a scheme. The canines and the bicuspids, they can also be delayed until 14 years. That is all right. You know, the canines, they have the longest eruption time. And I'm sure you will want to know at what age the primary dentition is completed. Well, we go back and see that it is half the 6, which means at the age of 3 years. So, with the number 6, which we can remember quite well, we can get along quite well also. So, if you see in a child that is older than 3 years, and the milk dentition is not yet completed, then that would be very unusual. Well, and the wisdom teeth at the very back, they come at 18 years of age. Sometimes they don't even come out, and some people don't even have any of them. So the development of the dentition is quite complicated. You know, several processes take place at the same time. Each tooth develops and acquires its individual form, and all the teeth develop at different speeds. And while developing, they move towards the oral cavity. And on their way there, which is different for each tooth, they resorb the roots of their deciduous predecessors, if they are replacement teeth, or if they're called successional teeth. And during root formation, the tooth-supporting tissue is also formed at the same time. And when the teeth just erupt through the gingiva, their roots are still not fully formed. You know, the last third of the root is still forming as the teeth reach the occlusal plane. And towards the end of tooth eruption, occlusal interdigitation is established, which is then when the teeth have to come into contact with their antagonists, pretty much very exactly. The teeth are guided into their occlusal interdigitation by the so-called cone funnel mechanism. According to the dental occlusal morphology with its slopes, the teeth are guided into the pits of their antagonists with the maximum contact. This cone funnel principle becomes effective as soon as the first contact between the teeth is established. And this is the critical time when an edge-to-edge bite must be corrected and a scissors bite prevented. One can look at the dentition a little bit as a clock. So people have tried it again and again to relate the dental maturity, which is the state of the dentition development, with the skeletal maturity. And in forensic medicine and anthropology, the age of individuals is also supposed to be estimated based on the developmental status of the dentition. But be careful. It does not work as exactly and as accurately as one would like to have it. The plus-minus deviations are individually quite large. So if you are satisfied to be as accurate as to 1 or 2 years, then we can play this game. So this model here shows a mixed dentition. Oh, please note, in this model, one milk tooth has fallen out and has been lost and not replaced. So just think of it as it would be there. So how old would you think this child is? We see that the deciduous dentition is completed, and then the child is at least 3 years of age. And the permanent teeth have not yet erupted, so the child is not yet 6 years old. So roughly the child would be between 3 and 6 years of age. If you want to be more precise, let us look at the developmental status of the first permanent molars and the permanent incisors. Well, then I would guess the age is about 4.5 to 5 years. But I cannot be more specific. And here we have a mixed dentition, phase 1. The deciduous teeth in the posterior region are still all in place. And the permanent incisors and the first permanent molars are fully erupted. So the child is at least 6 years old. Well, older than 6 because the roots of the erupted permanent teeth are almost completed. But the second permanent molars, which erupt at the age of 12, have not yet erupted, but they are sitting in the bone. So the child is not at all 12 years old. I estimate then about 10 years plus minus 1 year. I cannot do it any more precisely now. The individual variation is quite large. Here a summary of the timing of the emergence of the deciduous teeth. More details and the tables with the data and variations can be found in my textbook on page 417. You have certainly seen patients in whom the permanent incisors have erupted in an offset position. I mean, the lateral incisors in the upper jaw are standing partly behind the central incisors. This means that they have retained the position as when they were primordial prior to the eruption. This happens when the transversal development of the upper jaw is not sufficient enough. In the occlusal view, you can see very nicely on these transparent models, you can see the position of the incisors before they erupt. But normally, the maxilla should also become wider, and then the teeth should find enough space for a proper alignment after eruption. If the transversal development of the maxilla is not sufficient, so this crowded position of the tooth germs will not get any better during eruption, and then orthodontic intervention is required. It is therefore desirable that the deciduous dentition shows these interdental spaces. Spacing occurs because the maxilla becomes wider to give the emerging permanent teeth enough room. In the upper jaw, these gaps are usually more obvious than in the lower jaw. We can watch that again in a computer-animated movie. Here you see the difference in size between the incisors of the deciduous dentition and the permanent dentition. And here the permanent incisors make maximum use of the space. Their mesial edges lie directly parallel and close to the palatine suture. And when they erupt, they resorb the roots of the deciduous teeth and usually erupt with gaps. These gaps are then closed later when the canines will erupt. We will now focus on the anterior region of the mixed dentition, and we will see that the canines, when they erupt, develop quite interesting dynamics. When the canines erupt vertically, their crowns are very close to the roots of the lateral incisors. When they do erupt further, they first push the roots medially, which causes their crowns to move distally. The spaces, the interdental gaps that form in the anterior region, will be closed again when the canines will erupt completely. We can see similar dynamics very nicely here with my daughter when she was younger. This state of dentition is called the ugly duckling stage in some textbooks. With such a situation in the dentition, one would actually like to intervene and help the teeth and close the gaps immediately. Do not do that. In the past, some dentists pulled rubber rings over the teeth and they wanted to close the spaces then, but instead it happened, of course, that the rubber rings were rushing down the conical roots up to the tip of the root and then thus completely extracting the teeth. So, you must not do anything here. Nature takes care of it all by itself. So here, the right central incisor is leaning laterally because its root is pushed medially by the crown of the erupting second incisor. And on the other side, we see how this corrects itself. Because when the second incisor erupts, it pushes the crown of the central incisor medially again. So here we see on both sides, right and left, slightly delayed, what happens. And if a diastema remains in the middle, this is usually closed when the canines also erupt and push everything together in the frontal region. If not, we can correct that later, but I wait until the canines will have erupted completely. Here are the timing values for the mixed dentition again. And again, you can find the tables on page 418 in the textbook. And also, at this point, we can touch the topic leeway space a bit. This mixed dentition shows a crowding of the two central incisors, and at the same time, the deciduous teeth 3, 4, and 5. In the United States, it is A, B, C, and H, I, and J. They are still there. So the leeway space is preserved, and we have a space reserve of about 1 or 2 millimeters per quadrant. So there is enough space to correct the crowding and rotated tooth position. And now these models that we see here, they don't have anything to do with space balance. I just find these models so beautiful because they show the different stages of root formation and also the interdependency between the external shape of the roots and the extension of the root canals and the pulp. And as you see in the first bicuspid, in the upper jaw, they can even have 2 root canals, even if they have only 1 single root. During the second phase of the mixed dentition, the second molars reach the occlusal plane. If the bone supply in the apical region is sufficiently large, the premolars and the canines also erupt simultaneously. And if the apical basis is smaller, then the canines initially lag behind the premolars in the eruption, and this is particularly true for the maxilla. And if there is not enough space, a crowding can develop, as here with the lateral incisor, which has come into a crossbite. This must be eliminated beforehand. Now let us take a closer look at the leeway space. What is it exactly? It is a space reserved for the development of the dentition. The sagittal diameter of the deciduous teeth 3, 4, and 5, or in the United States it's ABC and HIJ and KLM and RST in the lower. It is actually larger than that of their permanent successors. So, although at the first sight you might think that the permanent teeth are always larger than their deciduous predecessors, this is not the case. This is because the bicuspids are smaller than the deciduous molars. And even if the permanent canine is significantly larger than its deciduous predecessor, there is still a space reserve of between 1.8 to 2.5 millimeters that can be used up by the dentition during the change of the dentition. And in the lower jaw, this is always somewhat more than in the upper jaw. You can see this here in a pair of plaster models on the right side of the patient, which means that this is in the left picture, where you can see that the 2 permanent molars are exactly perpendicular to each other with their mesial edges. The line drawn that illustrates this, and in some textbooks you will find the term post-lactal plane, which for me is very far-fetched. That's an artificial word for me, which means that the deciduous dentition ends distally in such a way that the 2 deciduous molars are exactly perpendicular to each other with their distal edges. The permanent first molars then initially line up in exactly the same way. Mesial edges exactly vertically above one another. That's then a edge-to-edge bite position. In the right picture, on the left side of the patient, the situation is already different. Here, the mesial edge of the lower first molar is clearly further mesial. There is already a nice cusp and fossa relationship, and the lower first molar could already move better mesially, simply because there was no longer this large deciduous molar in front of it. But it has already fallen out, and the bicuspid has taken its place. And because it is smaller, the first permanent molar could move mesially into a neutral occlusion. And in the panoramic radiograph of the same patient, you can also see this again nicely, although we cannot really measure exactly in such an image because we never know exactly which layer is seen in the projection. Nevertheless, you can clearly see the size discrepancies between the deciduous molars and the premolars. And then I have also drawn in red here the distances of the leeway spaces in all the quadrants. Perhaps also memorable is this picture, which shows a bicuspid in a slightly ectopic position and thus demonstrates the different sizes of the tooth crowns, whereby the mesial edge of the crown of this bicuspid is slightly below the gingiva. It is always amazing to me to see how the bicuspids manage to resorb the roots of the deciduous molars. The roots of the deciduous molars are very widely spread apart, and in this image we can see the huge distance between the erupting bicuspid and the distal root of the deciduous molar, which is already completely resorbed. This distance is probably about 4 to 5 millimeters. So here, whatever signals have to be passed on to the cementoclast and to the odontoclast from the crown of the erupting premolar, saying, here I come, and you, deciduous tooth, your root has to be resorbed now. And then it must also be ensured that the activated odontoclast really only resorb the roots of the deciduous molar and not the mesial root of the permanent molar immediately behind it. So for me, this is still a mystery how this is regulated in detail. And on the other hand, we also see situations where the erupting bicuspid has not managed to completely resorb the roots of its deciduous predecessor. Then a radix relicta remains. By the way, this was the first term in Latin that my son knew, because he had such a radix relicta and it had to be removed. How does it work that, on one hand, at this great distances that we have just seen, the resorption takes place, and here, in this case, much closer to it, the root is not resorbed. So for me, this is really an unresolved question. Here, the space for the canine is lost, because the first premolar has moved forward too early. Now we have to decide how to clear the situation for the dentition. It would be better if you would have maintained the necessary space in time, like here with the space maintainer placed in the right time. Regardless if upper or lower jaw, the principle is always the same. As a matter of fact, the leeway space can be used very elegantly if there is also a crowding of teeth in the anterior region. If we have determined that the anterior crowding requires space which matches about the amount of the leeway space, then we can solve the situation by simply preventing the first permanent molars from moving mesially, if the deciduous molar in front of it is shed. The space reserve is then about 1 or 2 millimeters per side. And that is, of course, enough to compensate for the crowding like the one we have here in front. What is going on can be seen very clearly here in the picture because we have a comparison between the right and the left sides. So on the left side, the second deciduous molar is still in place, while on the right side it is already missing and the bicuspid has taken its place. And you can see very nicely the space surplus distal from the bicuspid. And because the molars are held in place by this firmly cemented space maintainer, they are held in place by this soldered sublingual arch. The bicuspids on the right side can move distally instead. And the force for this movement comes from the cheek and from the lip, which are in contact with the teeth, of course. And what is already on the way to improvement on the right side will happen in exactly the same way on the left side after the second deciduous molar has also fallen out. And then the crowding in the anterior incisor group will be resolved and the space maintainer will have done its job. This can be further refined with a multi-bracket appliance. But you have to check the patient with that space maintainers on a regular basis. I do that every 8 to 12 weeks. That way, I would have seen something like this in advance. Here, the canine is coming out lingually under the sublingual arch. Of course, that should be prevented. And here, we are waiting for the canine. However, it does not have enough space for its emergence in the right place, and rather it would be deviated too far out. So at first we create space for its emergence at the proper place. We are using sequential aligners in order to move the upper front teeth forward a bit. And then we catch the erupting canine and lead it to its proper position in the dental arch. Here I can briefly show the permanent dentition with the timing of the eruption for each tooth. I do not have to go further into details here, as I said before. You can find further details in the textbook on page 420. Tooth eruption is a rather enigmatic process. As I will explain in a minute, many theories about how it works have been raised and have been proven wrong. And to be precise, the term eruption is not confined to the emergence of the dental crown only. Instead, it describes the entire process from the start of root formation to positioning the finished tooth in its final occlusal position. And if we look at this picture of tooth eruption, we can see that the single-rooted teeth, and there is attachment of new bone trabecula during their eruption, and in the multi-rooted teeth, there is not. And you know, the single-rooted teeth, the incisors and the canines, they lie deep in bone, and their eruption path is very long. And until they reach the occlusal plane, their incisal edges must cover a distance that is longer than the tooth root. And during the course of root formation, these teeth migrate occlusally, while bone remodeling and apposition of bone takes place simultaneously in the vicinity of the root. Bone apposition dominates in the area of the apex and also at the alveolar crest. In the picture that can be seen, for example, for the upper deciduous canine in figure 8, and in figure B, this is shown for a lower permanent canine. And as multi-rooted primary teeth and multi-rooted accessional teeth start their pre-functional eruptive movements when they do not lie so deeply in the bone, this additional bone formation is not observed there, as shown in the pictures C and D. Now, let us have a closer look at the question, why do teeth erupt? There have been a lot of theories and ideas in the literature in the past, which all turned out to be wrong in the end. Let us look at some examples. First of all, you might think that the growing tooth root should push the tooth out of the bone. To test this, animal experiments have been carried out, mostly on beagle dogs or on rats or the like, on rodents. In these experiments, the roots of the teeth were surgically shortened on the assumption that a shortened root would no longer be able to push the tooth into occlusion. However, this was not the case. Even those teeth whose roots were shortened, they did emerge, just like the teeth with no surgical alterations of the root in the control group. So it is not because of the root. It does not push the tooth out. So if it is not the root, it must be something else. Then they had the idea that it could be Hertwig's epithelial sheath, which is responsible for the eruption of the tooth. After all, it encloses the root tip from below, and this could be the driving force, they thought. However, this is also wrong for two reasons. Firstly, it is an artifact of histological technique that the Hertwig's epithelial sheath surrounds the root apex in such a kinged manner. This has turned out to be a shrinkage artifact. In fact, Hertwig's epithelial sheath runs pretty much perpendicularly. And then the argument that it could push the tooth towards the oral cavity is this way also not true. However, this has still been tested experimentally. Also, such teeth with completely removed Hertwig's epithelial sheaths, also again in the experiment with beagle dogs, also then the teeth without this Hertwig's epithelial sheath, they did all the way erupt. So it is not that one either. It was then assumed that perhaps the growth of the pulp is responsible for the eruption of the teeth. The pulp cavity is only really widely open apically, and if the expanding pulp could trigger a pressure then this would push the tooth like a rocket towards the occlusion, similar to the fireworks on Independence Day, which are also open at the bottom. Unfortunately, this was also wrong because the pulps were removed experimentally, which means root fillings were made. And then the teeth did emerge as if nothing was wrong. So the presumed expansion pressure of the pulp is also not the motor for tooth eruption. Another assumption then was that the bone growth in the periapical area that pushes the tooth to erupt. Again, experiments were done, this time removing the apical bone. And again, the teeth erupted even without apical bone. Then they thought that maybe it should be the desmodontal fibers. There is not much left now. They pull so nicely from the bone to the root surface. And if they contract themselves only slightly, then they could push or pull the tooth up coronally. This was also checked by scraping away the desmodontal fibers, which then healed. But after that, the teeth that had been abraded in this way actually did not erupt. There was then an ankylotic connection between the teeth and the alveolar bone. And well, ankylotic teeth do not move, we know that. So the desmodontal fibers could be the cause for the tooth eruption. That's what is believed to be true today, probably. Of course, it is not quite clear now how the tooth is moved pre-eruptively. In the case of tooth germs that do not yet have any roots, they then also do not have a desmodon. But at least it is now assumed that the post-eruptive force is generated by the desmodontal fibers. These were some exciting stories, I think. Now we are going a bit more into detail. After all, there is more modern knowledge about how the resorption processes of bone and predecessor teeth resorption are started on the molecular level. The first trigger for tooth eruption is not even the dental follicle, but the stratum reticularis, whose cells produce the parathyroid hormone-related protein. This protein, abbreviated as PTHRP, binds to the receptors of the cells of the dental follicle. Interleukin-1 alpha is also produced by cells of the stratum reticularis, which is also bound by receptors of cells in the dental follicle. The dental follicle is thus prepared by the stratum reticularis for its tasks during tooth eruption. The dental follicle, stimulated in the way, now secretes signal molecules that result in an increased accumulation of monocytes from the blood vessels of the dental follicle in the coronal region. And these signals include the colony stimulating factor 1, it's the CSF1, the monocyte chemotactic protein 1, the MCP1, and the vascular endothelial growth factor VEGF. These monocytes fuse and differentiate into odontoclasts or osteoclasts once they come into contact with the cells that produce rankle. In the dental follicle, rankle is expressed by the connective tissue cells, among others under the influence of the parathyroid hormone-related protein, the PTHRP, which is present there. The odontoclasts, which are also called dentinoclasts, are very similar to osteoclasts. However, they have fewer nuclei, are smaller, and their resorption lacunae are also correspondingly smaller. Their enzymatic activity is also similar to that of osteoclasts. And tooth eruption normally ends when the tooth has found its opposing tooth. But if there is no opposing tooth, no antagonist, then that tooth will continue to erupt, eventually until it grows into the opposing mucosa. We know this from lower anterior teeth in a deep bite situation, when they impinge into the palate, or here, also, the first permanent molar is without any antagonist. And you can see that it has already hypererupted somewhat beyond the occlusal plane. And by the way, we saw this in the lecture on facial growth. The teeth, in a way, continue to erupt throughout life, even if they are already in occlusal contact. We have to be precise here. And you might think, well, if the teeth always continue to erupt until they find their opposing tooth, then we have found a way to treat an open bite like that. However, this is not that simple. There are many causes for an open bite, and you can imagine that if the tongue is always positioned between the dental arches, then the teeth do not have a chance to emerge any further, and then we have an open bite simply because of the interposition of the tongue. So if the patient manages to normalize tongue function, usually with logopedic therapy, then the chances are rising that we can close that kind of an open bite. And here we see an example of a hyper-erupted bicuspid. It already has reached the gingiva of the lower jaw. The removable appliance is inserted for other reasons, like widening the arch, that holds it a bit. And after all, we can level the occlusal plane with that multi-bracket appliance. The staining of enamel that you see on the enamel surface has a different enamel defect, independent from the orthodontic treatment that we do here. Let us continue to follow the development of the mixed dentition in the anterior region. We can see a fairly large medial diastema here. I mentioned earlier that many patients do not want to accept this and ask for treatment to close it somehow at an early stage. Do not do that. Wait until all the teeth are there. You can see how closely together the roots are. Let us first see what the teeth do without our intervention. The canine crowns push themselves into the space distal to the root of the lateral incisors, and as we saw earlier, their crowns can even move distally. And only when the voluminous crowns of the canines reach the occlusal plane, then they push the diastema together at a large extent. When all the permanent canines have erupted completely, we can re-evaluate the situation and we can always go for some corrections. Before that, however, I do not do anything except that I observe how it develops. And here we see the use of leeway space in the posterior region as it happens with any dentition development. And here we are on the verge of the last deciduous molar falling out, and the bicuspid is taking its place. Another physiological observation is interesting here. Look at how deep the pockets are at the eruption of such a tooth. The periodontal tissue, the desmodontal fibers, insert at the cemento enamel junction of the erupting bicuspid. And since this bicuspid is still far away from the occlusal plane, the gingival pocket is also correspondingly deep, which can be as much as a centimeter. Here is the complete set of teeth, which we have to show here just for the sake of completeness. It is not specifically a problem of dentition development, but I would like to point out at least briefly where we can also be confronted with different developmental defects of dental enamel. These can be simple discolorations, or there are also influence of too high fluoride concentrations, traumas in which the ameloblasts can be damaged, or also this molar incisor hypomineralization, abbreviated as MIH, the causes of which are still obscure, or also known damages such as the amelogenesis imperfecta. In some cases, we observe situations like this. Here, the permanent teeth have missed the roots of the primary teeth on their way of eruption. They have slipped through palatally, and now the teeth are standing here in the second row, so to speak. The therapy is simple. The milk teeth, they have to be just extracted, and it must be checked whether the upper incisors are maybe in a crossbite. This must then also be corrected. It is very important that we take out milk teeth in time if they do not fall out by themselves, but if they prevent the positioning of the erupting teeth. I'm talking here about deciduous teeth where the roots have long since been largely resorbed, and some children don't let anyone touch them, even if the milk tooth crown is perhaps only dangling by a thread. But if you don't take it out, then a scissor spite can develop, as in this case, simply because the hanging crown acts like a wedge between the dental arches. And then the cone funnel mechanism could not work, and this is why a scissor spite developed here. This could have been avoided if the deciduous crown had been removed first. Sometimes they still hang on to a small leftover of a root, but we have to act. When roots are being resorbed, the material must go somewhere. Usually it is digested by the odontoclasts involved and giving back to the body the usual way. In some cases, you also observe pockets like these frequently filled with pus. Usually it is emptied when the deciduous tooth is shed. Some patients think that deciduous teeth do not have any roots. Well, when they fall out, the roots are resorbed and only the crowns remain, and then it looks like this. I think this picture is just beautiful. See how the tooth cusps are working themselves through the gingiva and present such a small gum bridge which spans over the fissure for a short time. The primary dentition is characterized by extensive abrasion. This can go so far that even the dentine cusps are exposed. This is due to the fact that the occlusion does not always fit together perfectly during tooth change and facial growth. If the deciduous cusps are ground flat, then the maxilla and the mandible can grow without any deep dental indigitation, preventing them from doing so. So, the abrasion of the deciduous teeth is a physiological process, and if you want, really quite good. Many children make these bruxism-like movements. You only have to make sure that they stop with abrading their teeth when the permanent teeth have erupted far enough. And sometimes you observe a so-called secondary retention of deciduous molars. After all, the occlusal plane was at the level of the deciduous molars at the time of the deciduous dentition. But when the permanent teeth erupt, the bite is raising. In most cases, the deciduous molars are also pushed up by this new bite plane level, partly because the permanent teeth push up their deciduous predecessors and their alveolar processes. But they can be wedged in, as they did here, and then they remain at the lower level. And now it is necessary to control the further change of teeth, perhaps in shorter intervals. You can see this again in this panoramic radiograph. You have to be careful that the permanent molars do not lean over or even jump over the deciduous molars mesially and prevent further eruption of the deciduous molars from their side. As you can see, after 2 years, the development of the bite plane elevation also goes its natural way in the premolar area. This situation is very unfavorable here. In this patient, all first permanent molars have erupted quite well, except for one, the lower left one, the molar number 19, is still stuck in bone. It is highly probable that this patient has a primary failure of eruption. As far as we know today, this is related to a certain genetic defect, with the consequence that the parathyroid hormone protein receptor does not function as it should. And now you know why we briefly mentioned also the molecular aspects of tooth eruption earlier. It just did not start there. And only a genetic test would provide certainty here, although I cannot explain why only one tooth and not all the teeth are affected by this genetic defect. So why does the tooth eruption work physiologically correctly with 3 molars and only with 1 not? How is it regulated that it only affects this one tooth or only one quadrant? An eruption disorder can also occur as a result of an inflammation, if an ankylosis has developed in the course of this. Now here we see another problem. In this panoramic radiographs like this, we often see quite well whether all permanent teeth are present, or, as in this case, which teeth are not present. In the first quadrant, 1 bicuspid is missing. No, 2 bicuspids are missing. And then in the second quadrant, both bicuspids are also missing, and the permanent canine is not in place. In addition, the left and the right permanent lateral incisors are also missing, and in the mandible, both second bicuspids are missing. So here we should have a plan quite early how the situation should be fixed orthodontically and in collaboration with the prosthodontist. And we have to find an individual solution for this patient. Timing of dentition development can come completely out of order, as you can see in this case of multiple aplasia, or also called hypodontia. There are many teeth missing, and I have marked with numbers those teeth that I could identify. This young boy is 6 years of age, but look, the lower canines that we see have an impressive size and have tremendously highly erupted into the oral cavity. We have to assume that these are the permanent canines already in the 6-year-old boy. For the American colleagues, I have given the tooth numbering according to the United States system into this radiograph. Again, we need to make a thoughtful plan here with a prosthodontist and an oral surgeon. It is also about keeping as much bone as possible for as long as possible. And where there is no tooth, bone will disappear. In cases like these, we should also check if maybe an ectodermal dysplasia is a possible cause for this situation. We see the opposite in this picture. Look how many bicuspids you can find. There should really be only 2 per quadrant, but take a closer look. So there are 4 or even 5 bicuspids in the lower jaw. This situation is not quite as bad. Here only 1 tooth primordium is present twice, but still interesting, here 2 deciduous teeth have formed. It is not that common, but it does also happen. And permanent teeth can of course also present hypodontia, as we have already seen. Here we have to decide which one of the 2 second incisors we want to keep and which one to take out. The one with the enamel defect is the obvious candidate to be taken out here. Not quite as rare are multiple teeth in the posterior region. Here an additional, a 9th tooth has formed. If we remove this additional primordium in time, then the 8th, which is the wisdom tooth, has a clear path for its eruption. And there are quite peculiar processes in connection with resorption going on. One might think that nature has everything well under control, that it has made sure that only milk teeth are resorbed, but not any permanent teeth. Unfortunately, this is not true. In this case, probably due to the close proximity of the 2 permanent teeth, extensive resorption has occurred on the first molar. So the situation is not so nice, but it can be saved by taking out the heavily resorbed first molar and placing the 2 distal molars to close the gap then. Also interesting is that not both teeth show signs of resorption, but only one. Why is this? Now we can summarize the big chapter about development of the dentition. Here is the take-home message. We have addressed the different types of teeth in regard to their role in development of the dentition. And we have seen the complexity and the dynamics of the development of the dentition, and we addressed some of the many theories about the mechanisms of tooth eruption. It is important to know then and to accept that the deciduous dentition is characterized by extensive abrasion of enamel, down to the dentine in many cases. And problems like primary failure of eruption, too many teeth, or reduced number of teeth was also addressed. And we have seen many clinical examples to show space management in such a way that each tooth hopefully finds its proper place in the dental arch. And with this, I thank you for your kind attention.